Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. I am super excited about this because we are going to have girl talk today. Dr. Marias is out of the office today, and I brought on a very special guest with us, Miss Kathy Fair, and we're going to be talking about women's health, particularly preconception and pregnancy counseling. This is something that we get asked a lot of questions as a primary care provider, and I don't know how to answer everything. So I'm super excited to learn from you today, as I don't have any children of my own yet at this time. And this is a big step and process that women go through their livelihood. And it's also for men. So men who are out there and our listeners, don't stop listening yet, because if you have a female in your life who is looking to get pregnant or is pregnant or even interested, this is something you should be tuned in as well and aware of everything that you also have to be involved with. So Kathy, go ahead and tell our audience how you got started and how you got to where you are today.
Well, thank you for having me today. And my name is Kathy Fair, and I'm a certified nurse midwife in Boca Raton, Florida. I have been in private practice for almost 30 years now. So wow. I started this journey actually as my sister's labor and delivery support person. Oh. I was with her in labor, and I just was so fascinated by the whole process. And I said, well, this is something that I want to pursue and I want to do. So that's where my whole process started. I went and I became a labor and delivery nurse. And then I was assisting, obviously, in those births and taking care of those women during the labor. And then I said, well, this is not enough for me. I want to deliver these babies, and I want to watch these babies grow up and then become their midwife when they're adolescents. And so I went back to nurse midwifery school and women's healthcare practitioner, and I graduated and I went right into private practice, and I've been doing it now for almost 30 years. So
wow.
Super
so I mean, you've been
in
the field for longer than 30 years, but actually private practice for 30.
Exactly.
Wow.
Yeah.
And so tell me the difference between seeing a midwife or APRN versus a physician.
We get asked that question a lot. And in our practice, we actually have OBGYN physicians and we have nurse midwives. So our patients can pretty much choose which direction that they would like to go during their, for all of their healthcare needs, actually, because as nurse practitioners and nurse midwives, we're able to take care of women throughout their lifespan. And this starts with adolescence. We take care of these young women for all their needs when they're younger, family planning visits, all of their annual well woman PAPs. And then we take them into their, pregnancy time and help them during their pregnancy and their birth and beyond and postpartum, and then take women through their lifespan well into their menopausal years. So as far as the difference between the two, I always tell my patients it's more about the personalized care, is that we all have that same level of education of taking care of patients for all their healthcare needs, but we provide a little bit more personalized care. It becomes a partnership. You really get involved with your women and you want to know about them and their families, and you want to just be part of their journey. So I think that's pretty much the difference. And then it frees the physicians up to do what they need to do, which is our high-risk patients and our surgical patients, and taking care of patients that is beyond our scope of practice. So I think between the two of us, we have a really good complementary practice and good collaborative care.
That's phenomenal. And I also will say I come to your practice and I have had nothing but a phenomenal experience, and getting to know you and Christine has been great. And you guys are very personal, and I love that.
Thank you. That's what draws a lot of people to our practice, is that we kind of take everybody on as family.
That's what I was going to say.
Yeah.
You feel like family. I mean, this is something that we are going down into lady parts. It's not something fun that people look forward to every year for their annual, or if there is something of concern or complication, you want to have somebody there that you feel comfortable with.
Yeah,
so.
Absolutely. And they feel comfortable from the minute they walk in the door. I believe you were our student once, right? Didn't you do a rotation with us?
No, not with you guys. No, but I will touch on my experience as a student. When I was up, I did a rotation in Illinois for my women's health, and I worked with a phenomenal OB that everybody loved. I actually didn't even want children until I delivered my first baby. And that experience made me see, the parents and seeing that this child came from them. And it just hit home. Like, I was like, wow, this is miraculous. A female carries this baby for 9 months and it's made from these two people. Like, I just saw it on a whole nother level that I never saw before. Before I saw pain. I was like, no, thank you.
No, it's just truly amazing.
It is.
It's so hard to believe that these babies were inside and now they're outside and bonding with their parents. So
exactly.
Just a great experience.
So I want to dive right into that. Let's talk about like preconception. What do you recommend for a female who is looking to get pregnant, or if they're in what I like to say, the fertile age? What do you recommend for people like that, even if they're not ready yet?
Well, we truly recommend that everybody comes for a preconception counseling visit, whether that be with their nurse practitioner, their midwife, their PA, or their own physician. It's something that is so important to get that proper education on what we can do prior to pregnancy to get our bodies ready. So we tell everyone to come in so we can identify any potential risk factors that might inhibit them from getting pregnant. And also I want to start them on prenatal vitamins and folic acid and all the important things that we know that I want women to be on prior to pregnancy. So I start them on a good prenatal vitamin, along with the omega-3s and folic acid.
Perfect. Do the omega-3s have to have EPA and DHA?
Most of the prenatal vitamins that we have today have everything included.
Okay.
So they only have to take 1 or 2 vitamins a day and still get all the essential nutrients that they need preconceptually, during pregnancy, and then also postpartum.
Okay. And so what about the folic acid? Because as you know, in our practice, we do a lot of genetic testing, and one of them is MTHFR, methyl tetrahydrofolate reductase. And we know that when somebody has a mutation of this gene, they're unable to convert folic acid into the L-methylfolate. And then therefore they can't go on the whole cascade of functioning. Their body basically brings me back to the Krebs cycle, which makes me feel icky. But, they can't get to the glutathione and the methionine and so on. So what about that? Do you guys recommend L-methylfolate as well?
We absolutely do. So that's a big word, right? When you're trying to educate your patients. So we tell them that there are a lot of conditions where women can't break their folic acid down to the most active form, where L-methylfolate is the most active form. So I'll start them on a prenatal vitamin that has that as their active form of folic acid. Preconceptually. So why are we going to wait for a woman to have a miscarriage or a woman genetically with a pregnancy that's genetically not right? We want to preventatively do these things and start women on these things prior to pregnancy.
Right. I mean, there's so many women out there who have this and don't even know.
Exactly. There's 50% of women that have MTHFR and have no clue. And unless we start doing the workup or you do the workup like you do routinely, no woman's going to ever know. So if I just treat everybody as if they have this, then we're one step ahead of the game.
Fabulous. And as we kind of touched on, that having this mutation does put you at increased risk of miscarriages and blood clots and many other things. But I hope to eventually have a podcast on it alone at some point. So when somebody becomes pregnant, what do they need to do? What's the first thing they need to do?
So we've already had our preconception visit. They go home. They start trying. This is what I tell my women. You might not get pregnant the first 1 or 2 months because everybody's expecting that that's going to happen, right?
Yes.
Everybody's on Google. Everybody has an app. And if these women do not get pregnant within the first 1 or 2 months, they think something's wrong. That's not true. It can take over 80% of women. It takes them over 6 months to actually conceive. So you've got to include that talk in your preconception talk, that they're not going to get pregnant the first month. I hope they do, but chances are if it takes 3, 4, 5 months, that's okay too.
I mean, we really only have one egg coming from, right, one ovary every month. So it's really
we have 24 hours a month to conceive.
Right.
And so think about that. That's really hard, especially for women that are working, traveling, their partner's traveling. It's hard to catch that fertile time. So I tell them that they need to be patient, they need to be relaxed, and they now allow their body to do what their body knows how to do. And that's when it's going to be successful.
Oh, and so I know you're not fertility specialist per se, but when do you suggest somebody sees a fertility specialist?
Well, what we tell our patients is that if we start doing a full workup on them, themselves and their partner, if they've been trying for over a year and have not been successful at that process. A lot of women don't want to wait a year. They start talking to me at 6 or 9 months and really want to start that workup. And I'm okay with that too, but I'll start that workup.
Right.
And I start, doing some testing on them to see what their ovarian reserve is and tracking their cycles and doing some follicle checks and things like that. And then I'll also offer their husband a semen analysis because that's important too. Because many times, believe it or not, it's not the woman, but it's their partner that they're actually having trouble conceiving. So we've got to consider this both as our patients. Absolutely.
In fact, I was listening to a podcast by Andrew Huberman. I listen to him a lot. He has very detailed, long podcasts, but he did a whole one on men's health regarding fertility with that and semen. And I learned a lot, and I didn't realize how that can change with age for men as well. Here we are always talking about the clock of a female, but it matters for men as well.
It absolutely does. And most couples don't realize that. And most women that walk through our door think it's them until we start doing the workup and find out that it could be both or it could be just the male partner. So we have to include everybody in this process.
And so how often when a person does get pregnant, what's the first time that they can get in with you guys? Or when do you recommend their first pregnancy visit is?
So our practice is really unique because we want them to come in early. We ask them to come in for a confirmation of pregnancy visit. So as soon as they get that home test, as soon as they miss their period, I like them to come in. I like them to get evaluated. And today, the tests that these women are using, they find out so early that it feels like it's such a long pregnancy because a lot of times they're getting a positive test even before they've missed their period because these tests are so sensitive. So they come to us, they call up, they get a confirmation visit, they come in, and we won't do an ultrasound that early, but we certainly will do lab work, and we want to check their pregnancy hormone levels, specifically progesterone. So many people do not include progesterone as part of this process, and progesterone is the hormone of pregnancy, and it's what's going to help women maintain that pregnancy until that placenta takes over at 12 weeks.
Am I right by saying that the progesterone is what keeps your endometrial lining thicker, and that's going to allow you to hold the egg or the ovum?
Absolutely. It keeps that lining so healthy that you can grow a healthy pregnancy. So I do progesterone levels at that confirmation visit. And if I find that they have a borderline progesterone or it's a little low, I start them on a progesterone supplement throughout that first trimester to help maintain that healthy endometrium and maintain a healthy pregnancy until the placenta takes over.
Wonderful. That was actually going to be my next question, is if you actually can supplement progesterone during that time.
Absolutely. And some women even take it longer if they have other, conditions that they might need additional progesterone to take throughout the pregnancy. But definitely first trimester for women that are in need of that.
And what about the HCG levels? So you do a quantitative HCG, I'm assuming, through the blood. And I know that's supposed to double, but what's the algorithm that you guys recommend? Because I know some women are they'll come into our practice, like if they're doing routine labs, and they're like, oh, I need to see my level, Yeah.
They ask for it because they do their homework. And like I said, everybody's Dr. Google, and they all want to know, well, my number's supposed to double every 48 hours. So what we do is we do a baseline. And if it's where I think it needs to be at that early part of their pregnancy, we leave it at that. But if I feel that it's a little too low or that I want to watch it and make sure that it is doubling appropriately and their progesterone levels are rising appropriately, I will repeat it in a week or two just to make sure we're all on the right track. And then once I know those levels are where I need them to be, I usually order an early ultrasound, somewhere between 6 to 8 weeks. So number one, so we can find out, make sure our dating's right on, and also check for viability and make sure that it's an intrauterine pregnancy and not an ectopic pregnancy. Because I certainly don't want these women going 9, 10 weeks, coming in with severe pain and have an ectopic pregnancy that I could have picked up earlier and possibly saved their tubes. So I find that visit to be so important.
And that's why I find it so shocking when I have other practices tell my patients that they can't get seen for their first pregnancy visit until like 11 or 12 weeks. I'm like, wait, why do you have to wait that long?
Yeah, and they don't. And we have so many people that call the office to make an appointment just because we will see them earlier. And we believe those first few weeks are so vital in the early part of pregnancy, and they need to be there and get that education.
Absolutely.
So important.
Absolutely. And go ahead and tell us, how long does a patient, or how often would they follow with you then thereafter? So say you did the early ultrasound between 6 and 8 weeks, you see it's a viable intrauterine pregnancy, they're on their prenatals, their progesterone levels are good, their HCG has doubled. What's next?
Well, you just described the most ideal situation, right?
Yeah,
we have a nice, healthy pregnancy. We all love that. The patients then will have what we call a new OB visit. And they've chosen to see a midwife now at this point during their pregnancy. And our new OB visits are pretty extensive because it involves a lot of teaching.
Okay.
Like I told you before, the difference between a midwife and a nurse practitioner, a PA, versus the doc is that level of education. We spend so much more time with them, educating them and talking about what we can do so they maintain a nice, healthy pregnancy. So that starts from day one. Traditional pregnancy care, we all provide that. But that personalized care, they're going to get from developing that relationship with their provider. We're going to include wellness as part of that, nutrition, healthy lifestyle, and also developing a partnership where you're going to develop a relationship with this patient so that they have trust in you, they have faith in you. You're bringing their baby into their world. And I want this to be an entire family process. It's not just about the woman and myself. It's about including her partner or her spouse or her other family members, whoever is going to be her support person. And that we want to have really good shared decision making there so they know that they're being heard. And I know that they have faith in me and that we can develop this good trusting relationship throughout the pregnancy. So once that begins, we see them every 4 weeks until 28 weeks. And then once at 28 weeks, we start coming every 2 weeks until 36. And then 36 is every week because so many things can happen during the last few weeks of that pregnancy that I want to monitor them very closely. Blood pressure, growth of the baby, all those things that women don't realize are really a high potential of developing problems toward the end, and we want to see them more often during the end of that pregnancy.
So what are some, I guess, could you list a few complications? You mentioned already the blood pressure, which I know I'm familiar with that. You don't want preeclampsia. That's a familiar term. And I know the size of the baby makes a difference. And that could be also indicative of probably like the diabetes during pregnancy.
Absolutely. All those things we monitor so closely. So once we hit, everybody has a 20-week anatomy scan. That 20-week anatomy scan is going to show if there's any markers that could be indicative of the baby having a problem. So we're looking at the heart and the lungs and the kidneys and the spine and just making sure that that pregnancy is developing appropriately. And then after that, they usually have a third trimester ultrasound where, again, we're watching the growth and the fluid and the placenta and making sure everything is right on track. But at 28 weeks, they will start their glucose screening. And that's where we screen for gestational diabetes, a very common condition that women get in pregnancy. They could do everything right. They could eat right. They exercise every day. They do everything right. And they can still develop gestational diabetes that then has now turned their pregnancy into a higher risk pregnancy where we have to monitor them more closely and do more frequent ultrasounds and watch the growth of the baby and just make sure we have a healthy mom and a healthy baby as we near toward the end of the pregnancy. So diabetes is definitely one of those conditions. As you said, hypertension. huge. We watch women all the time. We call it now gestational hypertension when it starts earlier in the pregnancy. And of course, you mentioned preeclampsia or pregnancy-induced hypertension that we get more toward the end. Okay. And again, once these conditions develop and our pregnancy is term, we want to get those babies out. We want to talk about a safe, healthy delivery and not wait for mom to get sicker, because now it's about the mom, to me, about keeping her healthy and making sure she's able to have a healthy delivery. So it's a long process, but one that's monitored very closely.
Wow. And I'm assuming, medications is something that comes up a lot with pregnancy. And what about, like, for blood pressure, you're only allowed like 2 different options, right, that are safe for the baby and mom for hypertension during the gestational? Absolutely.
So great question, because some women come in, remember we talked about preconception already, they come in with chronic hypertension. Mm-hmm. So they're already on certain medications for hypertension when they come in for that preconception visit. So I make sure that we change them to a medication that's going to be safe in pregnancy, because we have to say, do the benefits outweigh the risk? I need to keep her healthy to have a healthy pregnancy, but the medication that she may be on might not be safe for pregnancy. So that's my job as her provider to switch her to something that's going to be good for her, keep her blood pressure stable, but also have a healthy pregnancy. So medications are so important. Hypertensive medications, thyroid medications. We monitor women all the time throughout pregnancy for thyroid problems. And they may come to you, again, preconceptually with hyperthyroidism or hypothyroidism and already be on medication. But now they get pregnant, your hormones change, the levels need to be monitored closely, and those medications need to be adjusted appropriately as well.
And your goal for thyroid is keeping a TSH between 1 and 2?
Yeah, I like my numbers between 1 and 2. I keep a really tight control. When they start creeping up, that's when I'll start adjusting their medication. Or this might be a mom that never had a thyroid condition in the past, but now pregnancy, she's a little sluggish and we might need to add something. So I try to keep it really tight control between 1 and 2.
And in our practice, we're big fans of the desiccated thyroid. We use a lot of NP thyroid or Armour because it's more natural. Is that something that you automatically switch patients to Synthroid or levothyroxine, or are you okay with them being on the desiccated?
So we are, if they're already on this medication prior to pregnancy, I'm not going to reinvent the wheel. I'm going to keep them on something that we know is safe in pregnancy. And there's really been no studies to show differently. And there has we haven't seen any studies that show adverse, outcomes by keeping them on the medication that they're on. If they develop hypothyroidism during the pregnancy, our main medication we usually start them on is Synthroid or levothyroxine, which we also know is the safest medication in pregnancy.
Right.
It's a category A. It's not going to hurt mom. It's not going to hurt the baby. It's just going to potentially keep everybody healthy enough to have a healthy pregnancy.
And that's what people don't realize. Having an abnormal thyroid can actually be more harm than taking that medication.
Absolutely. But again, that's our job as their practitioner to educate them on that. And when they have trust in you, they have faith in you, they're going to do what, we recommend together as a team. Also, let's touch on some of the antidepressants.
I think we were looking at each other, reading each other's minds.
This is so big.
Yes, it is.
And women are on a lot of antidepressants now, sadly to say, but I also have to say again, do the benefits outweigh the risk? And we need to keep these women healthy. I have seen so many practitioners try to take women off of their antidepressants preconceptually or during the pregnancy, and that is not the healthy thing to do for these women. And so again, we keep them on medications that we know are safe during pregnancy, and there are some that are not. So if I meet with a woman prior to and she's on a medication that I would not recommend during pregnancy, I switch her, or I call her therapist or her psychiatrist or her primary or who's ever managing the condition at the time. And we work collaboratively together to find a medication that's going to keep her healthy but be safest for the pregnancy.
Exactly. Mental health is huge. And that kind of goes back to, I think, a lot of the L-methylfolate. I think a lot of people don't realize how MTHFR mutation can actually play a role in depression and anxiety and mental health in general. And if they get on the L-methylfolate preconception, that might also help a little bit. I'm not saying it's going to get them off the medications completely. We've been able to have patients who have been able to get off their antidepressants by starting an all-natural supplement, but I don't make promises for everybody. And this is something that would only work in conjunction with and help during that transition.
100%. Like I would call you and say, listen, what do you suggest here? Or how about we try this? And we use a lot of the L-methylfolate for that reason. And many times we start them on that before we start them on an antidepressant. And we follow these women and they do fine with it. So again, big issue during pregnancy, and we got to take care of it.
I'm going to go off topic a little bit here because I just thought of a question. During pregnancy, I know there's certain vaccinations that are recommended for the mother and even close family around. Could you touch on what your recommendations are on that?
100%. So obviously, the flu vaccine is recommended during pregnancy. COVID vaccine is also recommended during pregnancy. But the main one that we recommend to everybody, which is an American Academy of Pediatrics recommend, is the Tdap. Tdap, we start educating our women around 26 weeks on taking the Tdap vaccine anywhere between 26 weeks and 36 weeks of their pregnancy, specifically for pertussis, or what you know of as whooping cough. And we want these women to be protected, but we also want the baby to get some of that protection. Because you and I, we have a good, healthy immune system. We can fight things off, but a newborn baby can't. And so what the American Academy College of Pediatricians recommend is that every parent, grandparent, anybody coming in direct contact with this baby have a recent vaccine. And so if a woman's had a baby with me 3 years ago, every family member has been vaccinated, they're good to go. But the woman should have it again. So what they recommend is that we as women get it with every pregnancy. So not just with the first, we continue with every pregnancy. And that's the current recommendation. It's not mandatory. It's a recommendation. Okay. We're certainly not going to tell these women they can't take their babies home because they did not take a vaccine. It's a personal choice. It happens all the time. We tell parents to go, like we want them to see us preconceptually. I want them to meet their pediatrician prior to having that baby so they can talk about all those issues too, about what the pediatricians require, what their recommendations are. And again, develop a team approach so they can both work together in raising that healthy child.
Yeah, I think that's a very important step so that parents can be on the same page with pediatricians and have their plan marked. I think you definitely need to interview because your not morals, but your goals for your child might not meet the what the pediatrician insists on per se, and you want to be able to have a good working relationship.
Absolutely. And then they're going to have a little faith or trust in that pediatrician and be able to compromise and work together as a team.
So I'm not sure if we've touched on everything yet, but I am very interested in learning about the childbirthing part. And you do a lot of education for childbirthing.
I am a childbirth educator. I've been a childbirth educator for probably longer than I'm a midwife, well over 30 years. And when I had my first daughter, we took a childbirth class. We didn't learn anything. My husband and I felt like we were like blinded, like we didn't know what to expect. And so when I started this process, I said, well, I'm going to make sure that when these women come out of our classes, they know what to expect, how their pregnancy is going to go, their delivery, and know that they have choices. This is the thing is women don't realize that they have choices. Okay. And so our classes, I call it a childbirth education class. It's not a Lamaze class. It's not hypnobirthing. We include everything in the class. And this because everybody has a different want or need for how they want their birth to go. And so I always teach them and educate them that we need to be open-minded because we never know what's going to happen in that birth process. I don't want them to be locked in to certain ideas and then a problem arises and they feel like they don't have any control or have any choices in their labor. So we educate them on everything. So I start teaching classes usually in that third trimester, and we talk about what's going to happen during the last 4 weeks of their pregnancy, what's going to happen during that entire birth process. And then let's not forget that postpartum period, because so many women don't realize what postpartum is going to entail. and how their mental health will be affected postpartum and with breastfeeding and everything. So, but remember, when these women start labor, they started at home. We're not with them at home, right? So they're having to make decisions of when to go to the hospital, what to do, signs of labor between them and their partner or their doula, and we're not with them. So we ask them to call us and tell them what's going on at home so I can kind of guide them in the right direction. And I also share with them a lot of good comfort or relaxation tools that they can be doing at home that's going to make their labor easier, and then guide them when's the right time to go to the hospital. So that's all part of that childbirth education, because what happens to most women, they start having contractions, and what do? They rush right to the hospital.
And it's not time yet.
Exactly,
per se, right?
Exactly. They get there and they're told they're not in labor, or it's too early to be there, and they get sent home, and then they get frustrated because they said, well, if I thought I was in labor now, what's going to happen when I'm truly in labor? And that's where that education comes in, and good teaching. And I think with classes, it's actually proven that couples will have easier labors, they'll have shorter labors, and they have safer outcomes because they're really being educated on what's going to happen in that process. And they're not listening to social media, and they're not listening to what their friends say, and they're really having faith in us as their provider so we can have a good, healthy, safe, outcome.
The one thing I can say is I have several people who have delivered, and they're all different. Not one person has the same delivery schedule or anything. And same with different pregnancies. This, same woman, different pregnancies are different each time.
100%. And, we could sit here today and say, this is how I want my birth to go. And then they go into labor and it's exact opposite of what they were planning. So I want them to be prepared for that. I want them to know there are things that can happen during the labor where it might change some of our choices. But we can compromise and we can work together.
I like that you do that, because a lot of people, like you said, get so set in their way. They're like, well, I'm going to have the epidural right at this time. I know I'm going to have this, and this. And, they might have their night bag planned. Well, guess what? That baby had other plans, and that baby's on its way. And now you're already dilated and you are ready to go, and there's no time for an epidural. And then it's like, what now? And, you have to mentally be prepared for that.
Absolutely. They miss that time period, and that baby's coming, and they don't know how to focus. But we work together as a team, and we get them through it. And the next day, they realize that they didn't need that epidural. Their body did exactly what their body was supposed to do. But then you get also the women that have very long, drawn-out labors. They're so physically exhausted where they may need to incorporate some of those relaxation techniques into their labor because they're fighting labor. So again, we've got to just really work together as a team and know what's going to be best for them.
And I know it's also something that women have to face, whether they want a natural birth or like a cesarean, or a vaginal birth versus cesarean. And unfortunately, I know there's been times where there's complications and they have to have a cesarean, whether they want it or not, but it's better for the baby and the mom. So...
and then again, that's part of our education process. In our childbirth class, we include that. We teach them all the potential things that could happen where they may end up a C-section. And if you walk out the hospital with a healthy baby in your arms, I don't care whether that baby came out vaginally or came out a cesarean section, we were successful if you have a healthy baby in your arms. And that's, again, encouraging them to be open-minded and expect the unexpected, because we never know what labor is going to entail.
Exactly. So after the labor, now what are their options? Now there's, cord blood donation, or what do you suggest? Or
yeah, so that's a huge question that comes up with our families. And cord blood banking has been around for a long time. Cord blood banking is banking your newborn stem cells for your family's future. We bank the cord blood, and we bank the tissue. And what we can do with cord blood today versus what we could have done 20 years ago is just amazing. We teach private classes for that as well. I mean, that takes a separate class to tell these parents what their options are. Currently to date, we can treat over 90 different FDA-approved conditions or diseases with stem cells. So that's huge. Where 20 years ago, we might have been able to treat 10.
Wow.
And so I always say, well, look at what the future is going to hold. The tissue is really our family's future because the tissue is regenerative medicine. We have the ability to use that tissue for multiple transplants and for everybody. The cord blood is a direct match to your child, 100%. It's a 75% match to a sibling, 50% match to a parent, and a 35% match to a grandparent. So in the event that a family member needs a stem cell transplant, where do we go? Directly to the stem cells that we already have stored as part of our family banking, where the tissue can be used for anybody. So you could use it for your cousin or your sister or even your neighbor if you chose to. But I believe it's a choice that parents make, which is probably the first biggest choice that they're going to make of banking their newborn's cord blood and cord tissue for the future.
How long do they have to make that decision?
Well, we only have one opportunity to collect it, and that's at the time of delivery.
Okay.
So we hope that they've already made that decision prior to. They've already contacted a cord blood banking company. They have the kit. They're all ready to go. And then their provider, we're the ones that do the collection, and we're the ones that package it up, and then they call the courier, and it gets shipped directly to the company. But I never want a parent to be in a situation where they say, woulda, shoulda, coulda.
You're right.
You know, and it has through the years and the research that's been done, it is so affordable to parents now, because I'll be honest, 20 years ago, it was super expensive. Mm-hmm. And the main reason that couples did not do it many years ago was for cost and cost only. And now we've made it so affordable. To me, it's a no-brainer. It's something that should be just part of your planning for your birth and planning for your delivery, and you do it for every pregnancy.
I mean, this could affect somebody, your child, when they're like 50 years old, right?
100%.
I mean, it doesn't.
It never gets old, right? It's cryopreserved, so it's frozen in time, and it's frozen in time. It's in its most pristine condition, so there's no time for damage to occur. If you take my stem cells, they're damaged through wear and tear. They're not in their healthy condition, but a newborn stem cells are in their most healthy, pristine condition. So we're basically freezing them in that condition in the event that we need them 25 years from now. And think about what we're going to be able to do with them 25 years from now. I had one couple many years ago. She didn't do cord blood banking, and she didn't do it for cost and cost only. And her child got sick at 2. And he gets diagnosed with a rare form of cancer. He goes through all the traditional treatments, chemo, radiation, you name it, and he needs a stem cell transplant, and they cannot find a match for this little boy. And they encourage the parents to get pregnant again with hopes that they can have a sibling transplant. Yeah. Because as I just said to you, there's a 75% chance of a match to a sibling.
Right.
So their plans were to get pregnant again and get the cord blood and do everything that they need to do, but he passed away before we could have an opportunity to do that.
Oh.
So it was probably one of the hardest, times for me, because she came to me and she said, talk to your families about this, because I put a price tag on my child's life. The only reason why I didn't do it was for cost and cost only. And we don't know if it would have been successful.
Right. You can't blame yourself.
No. You can't go back and say, woulda, shoulda, coulda. You can't change your mind. It might not have worked, but they never had an opportunity to try. And then they know that they could not find a match for this little boy to have a stem cell transplant. So to me, it's something that I plan for my family's future. I have 4 grandchildren. They're all banked. I've got another one coming. She's going to be banked. And I hope I have a family pool of stem cells that sits there forever, and I never need them.
Exactly. I mean, it's no different than having insurance, right?
Exactly. It's a life insurance policy for your child.
That's exactly it. Well, I do have a couple questions I'd love to ask. So we've already touched on, prenatals, and so you recommend people to get started on a prenatal, at childbearing age, basically. Is there one that you specifically recommend, or are they all pretty much good at this time? They're
all pretty much the same. Again, I will tell my clients about making sure they have enough folic acid, because we touched on that already. That folic acid is so important preconceptually, decreasing the chances of neural tube defects, spina bifida, miscarriage, so many things. and hypertension. I mean, it really helps keep our women healthy. And so I want them to be at least, and they look at the over-the-counter prenatals, and many of them only have a small amount in there. Yeah. So I encourage them to either take a prescription prenatal that I'm going to prescribe to them, or make sure they take an additional folic acid on top. So I want at least 1 milligram or 1,000 micrograms of folic acid in their prenatal or as an additional supplement. Perfect.
And that's what I've always heard too. And it's amazing. Like you said, I've seen like 400 micrograms or 600 or 800. Yeah. And so
certainly not enough for my liking. And that's why I like a prescription, because a prescription is going to have at least that, if not more.
Okay.
And some of the ones that we use, again, have more, and they have the most active form of folic acid. So we're not worried about their body not being able to metabolize it.
Awesome. And then what are some chronic conditions that make it harder for females to get pregnant?
Oh my God, we have so many of those, but some of the ones that we already talked about, you and I already talked about gestational diabetes, but what about these women that were diabetic before, or they've had, juvenile diabetes, and they've lived their whole life monitoring their sugars and on insulin pumps? These women can get pregnant. They can take their insulin. They can have healthy pregnancies. We just monitor them more closely. Or that woman that has that chronic hypertension, like you already talked about, in making sure they're on the safest medications to keep their blood pressure stable, but have something that's not going to be an adverse effect on their baby or their pregnancy. And then there's a lot of women that may have conditions where they don't ovulate on a regular basis. And I see this all the time. Polycystic ovarian syndrome, where these women do not ovulate regularly. They don't get regular periods. They may come in and share with me that they get a period every, 2 to 3 months. So we just said you have like 24 hours during a month to conceive. Well, these women may only ovulate once every 3 to 4 months.
And on top of that, they don't know what day it is.
Exactly. So it makes it much harder for them to conceive. So we talk about how we monitor that and how we can get them on medications to help them with ovulation and help them to conceive a little quicker.
And we did a podcast on PCOS before, and we're not a fan. Obviously, they can't be on birth control if they're trying to conceive. So I like that there are other options, and you can help regulate that. And so at what time do you guys decide if somebody wants to know the sex of their baby? What time frame is that?
Well, now it's much earlier than it used to be. Back in the day when I was having my babies, we didn't find out until that 20-week anatomy scan.
Wow.
Where they could actually look and look at the anatomy and tell the gender. But now we have such great testing. We do a test called an NIPT, non-invasive prenatal testing or screening, which we can do anytime between 11 and 13 weeks now. Now, the true meaning of this test is to screen for any aneuploidy. That means to screen for any Down syndromes, trisomy 13, 18, 21, and any microdeletions. So that's the true meaning of the test. But incidentally, we can find out the gender from that test. Oh. So because social media, we have women that come in all the time, and when can I get that test? When can I find out my baby's gender? And then I explain to them the true meaning of the test. And I said, I'm going to call you with the results of the test. Make sure we have a healthy baby. Then you tell me how you want to know the gender, if you want it in an envelope, you want someone to pick it up. Right. We all do these great gender reveals now. But they still forget when you call them about what the true meaning of the test is. Oh, what's the gender? When can I find out? So we can find out early now between 11 and 13 weeks.
That's great. And it's not invasive.
Correct.
Because that's actually one of my most important things, because that's actually a fear of mine, with having a child. You're a healthy human being and you want your child to be healthy too. And that's a big curiosity. And so that's great, because they used to have to do a placenta biopsy, right? Or
right.
The amniotic fluid.
Right. So many years ago, before we had this kind of testing, the only way that we could really do any diagnostic testing was to do an amnio. And an amnio is done anytime, 16, 18, right. 20 weeks, where we go in and we take some of that amniotic fluid, and that looks up at the chromosomal level of the baby, which will screen for all those Down syndromes. Right. But it also puts the pregnancy at risk. And so now we have such great testing, which is non-invasive, gives us so much information, 92% sensitive, so that's excellent. And it goes hand in hand with an ultrasound called an NT ultrasound, where we actually measure the thickness of the baby's neck. And we know babies with Down syndrome have a thicker neck fold. So by doing these two tests together, you're pretty much saying that we have a nice, healthy baby by 13 weeks.
Wow, that's phenomenal. Because, even when I was in PA school, I learned it the old way. So
yeah, we all did. I mean, that's how I knew it. And so it's a great option to have for women. Most women decide that they want to do those testing. And again, everybody does it for different reasons, but we want to make sure we have a healthy baby.
And I think nowadays the people they were doing 3D scans. Now is it 4D scans?
4D.
Wow.
Where you look at that baby, you see those facial features. You basically know what your baby's going to look like before your baby comes out.
When do they suggest you do those?
You must do that later on. Okay. So usually between 28 and 32 weeks are the best time. So you can get really good views of the baby. If you do it too early, you're not going to see much. And then if you do it too late, they're so crammed up in there that you really don't get good pictures of the face.
That makes sense. And do you guys do that in your office?
We can, but most parents go to those fun places where they make videos and do all that together.
I've heard about those.
Yeah,
okay. Yeah. Wonderful.
So there's nothing diagnostic about that ultrasound. Right. It's all for fun. It's all for the pictures. And they just, put it on a video for them, put it to music, and just make it something enjoyable.
Wow. Well, Kathy, this was a phenomenal podcast. I am so glad to have you on. I learned so much, and I hope our audience did too. Why don't you go ahead and tell them you have a website. What is your website?
We do. I sent it to you.
So it's the Midwifery Women's Care.
Yes.
All right.
Our practice is located in Boca Raton. We are at 900 Glades Road, right across from FAU. And I had sent you the website earlier.
Midwiferywomenscare.org.
You got it.
I'll also post that in the show notes.
Yes, please. And you can go on and see all the services that we offer. But basically, it's any care from adolescence through menopause. We take care of women throughout their lifespan.
And what's your office phone number?
It is 561-430-3933.
Thank you so much.
And thank you for having me. This was a lot of fun. Thank you.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.